All right, welcome to The Explainer. Today we're tackling one of the most high-stakes skills in the entire ED, troubleshooting a ventilator. Look, this is way more than just knowing the buttons and dials. This is about what you do when the alarms are screaming, your patient is crashing, and you're the one who has to fix it.
So let's kick things off with a number that really sets the stage: 48 hours. That's it. After just 2 days on a vent, the risk of ventilator-associated pneumonia, or VAP, just skyrockets. And that's just one of the things that can go wrong. We're talking barotrauma, cardiovascular collapse. These complications are super common, and your ability to respond systematically and, fast is what's going to make all the difference.
So picture this. The alarm goes off, that high-pitched beep just cuts right through all the chaos of the ED. You look over, your patient's SATs are dropping, their BP is in the toilet. This is the moment, right? It's what every single emergency registrar dreads and prepares for. Being ready isn't just a nice-to-have, it's absolutely essential. So today, we're going to build a framework, a system, so you can answer this question with total confidence every single time.
Okay, so here's the game plan. First, we'll tackle what to do when those alarms go off. Then, we'll build a system for any crisis. After that, we'll get into some disease-specific strategies, walk through a high-stakes scenario, and wrap it all up with the critical takeaways. Let's get into it.
All right, Section 1, when alarms go off. You know that jolt of adrenaline you get when the ventilator alarm starts blaring? Well, the key is to remember those alarms aren't just noise. They're basically vital signs coming from the machine. They're telling you a story about the patient, the circuit, or the vent itself, and your job is to become a master translator and do it fast.
So, when it comes to alarms, you can pretty much boil them down into two big buckets: high pressure and low pressure. And honestly, this is the most important first step. Think of it like this. High pressure means there's a blockage. The vent is trying to push air through a straw that's kinked. Low pressure means there's a leak. The air is escaping out of a hole in the straw before it even gets to the end. Blockage versus leak. That's your first mental fork in the road.
And why do we care so much about getting this right? Well, because the stakes couldn't possibly be higher. If you get it wrong, or even if you're just too slow, you're looking at severe hypoxia, barotrauma, like a pneumothorax, ventilator-induced lung injury, or even total cardiovascular collapse. This is exactly why winging it is not an option. You need a system. It's the only way you're going to get it right when every second counts. Okay, so how do you actually do that? How do you go from chaos to control? You need a system. A repeatable, reliable pathway that gets you from the alarm to the answer every single time. And it's actually pretty simple. You always start with the patient first. Get your eyes on them. Are they fighting the vent, biting the tube? Okay, patient looks okay. Now work your way back. Check the circuit. Trace it with your hands from the patient all the way to the machine. Any kinks? Any water in the tubing? Nope. Okay, next. Check the endotracheal tube itself. Is it blocked with gunk? Has it slipped out? And finally, grab that stethoscope and listen to the lungs. Anything new? A wheeze? Or, and this is the big one, is the air entry gone on one side? So that's it. Patient, circuit, tube, lungs.
Now, this brings us to probably one of the most important numbers on that whole screen, the plateau pressure, or P-plat. Look, the peak pressure that sets off the alarm, that's the pressure for the whole system, the tube, the airways, everything. But the plateau pressure, that's the real pressure down in the delicate little alveoli. That's the number that tells you if you're about to cause lung injury. And the rule is simple. It is a hard, fast, non-negotiable rule. Keep it below 30. For everyone.
Right, so the best troubleshooting is actually proactive. It's about setting things up right from the start. So let's dive into some specific strategies for 3 of the big, challenging presentations you're going to see in the ED.
Okay, first up, the severe asthmatic. The big bad guy here is something called air trapping, or auto-PEEP. Basically, their airways are so tight, they can't get the air out. So our entire strategy is built around giving them as much time as humanly possible to exhale. How do we do that? We drop the respiratory rate way down, like 6 to 8 breaths a minute. We use zero PEEP because that can just make the trapping worse, and we give them a super long time to breathe out. We're talking an I to E ratio of 1 to 5, maybe even longer. It's all about letting that air escape. Now let's flip to a totally different scenario, a traumatic brain injury. Here, it's all about protecting the brain. The enemy now is secondary injury. The big thing to remember is you cannot, absolutely cannot hyperventilate them. Why? Because if you blow off too much CO2, the blood vessels in the brain clamp down, and you can actually worsen the ischemia. We also have to be really careful with PEEP because it can raise the pressure inside the skull by making it harder for blood to drain out. It's a completely different ballgame.
And finally, ARDS, Acute Respiratory Distress Syndrome. For this, we use the ARDS net protocol, which is all about lung protection. You have to imagine these lungs are like wet, stiff, fragile sponges. They are so easy to damage. So the key is tiny tidal volumes. We're talking 6 milliliters per kilogram of their ideal body weight. This is crucial to stop us from overstretching and injuring them. And completely opposite to asthma, we actually use higher levels of PEEP here. The goal is to pop open those sick, collapsed little air sacs and keep them open so they can actually do their job.
Okay, theory is great, but putting it all together when the pressure is on, that's what really counts. So let's run through a high-stakes scenario. Put yourself in this situation. You're right in the middle of a crazy shift.
So your patient is a 45-year-old with a severe asthma attack. You've just intubated them, and you've dialed in those asthma-safe settings we just talked about. Low rate, tons of time to exhale. Everything seems stable. You're about to move on to the next patient.
And then, suddenly, the alarms go off. You look at the monitor, and your heart just sinks. They're profoundly hypoxic, and their blood pressure has completely bottomed out. A sudden crash like this on the vent is one of the biggest red flags you can get. It needs your full, undivided attention right now.
So you immediately run your system. Patient is unresponsive. You check the circuit. It's fine. Tube position? Looks good. Then you put your stethoscope on their chest and you hear nothing on one side. Total silence. So let's put it together. High peak pressures, no air entry on one side, and complete cardiovascular collapse. What is the one thing this has to be until you prove it's not? A tension pneumothorax. No question. And here is the absolute most important takeaway. What do you do next? You do not wait for a chest x-ray. You don't wait for anything. Your very first move is to disconnect the patient from the ventilator. That stops the positive pressure that's building up. Your second move is to grab a needle and decompress their chest immediately. That is what will reverse the shock. That is what will save their life.
Whew, okay, that scenario really drives home how critical this stuff is. So let's boil it all down to the absolute must-know, non-negotiable takeaways that you need for your next shift.
All right, these are the pearls. If you walk away with nothing else, remember this. 1. Plateau pressure under 30, always. 2. For asthma, think slow rate, long exhale time, no PEEP. 3. For head injuries, keep that CO2 normal. 4. For ARDS, think tiny volumes and more PEEP. And finally, it's okay to let the CO2 drift up a little in asthma and ARDS. We call that permissive hypercapnia, as long as the pH stays above 7.1.
And here's the mantra I want you to burn into your brain. Sudden deterioration on the ventilator always means pneumothorax until proven otherwise. In that moment of crisis, when a patient is crashing, that single thought process will keep them safe, because it forces you to find and fix the most immediate threat to their life.
Now, we've gone through my system, but I know you guys have your own tips and tricks that you use every day. So let's build a little community knowledge base here. What's your favorite troubleshooting tip? Do you have a mnemonic that saves you? Drop it in the comments below. And hey, while you're down there, let us know what topic in emergency medicine you want us to break down in the next explainer. And finally, if this was helpful for you, do me a favor and hit that like button and subscribe. It really helps us make more of this practical, high-yield content that's built for busy docs like you. Thanks so much for watching.